And I think one of the reasons veterans don't seek care is they have a misperception of what care would look like. So they have a lot of ideas. One is that I'm going to be medicated constantly, and I don't want to be medicated, or that I'm going to have to sit and rehash all of my traumatic experiences with a stranger, and I don't want to do that either. And so a lot of times people aren't seeking help because they don't know what the process looks like, and that so many other things can be helped without even, you could get better without even talking about your trauma at all. So there are so many other things that can happen. And I think there's not a lot of education about the therapy process in general.
Welcome to the Change Your POV podcast. You're listening to Headspace and Timing, a show dedicated to breaking down the stereotypes of veteran mental health. I'm your host, Dwayne France. Let's get ready to make sure that your headspace and timing set correctly. Hey everybody, welcome to Headspace and Timing. If this is your first time listening, then thanks for checking us out. As many of you who serve know, the M2 machine gun, the 50 cal, is one of the greatest weapons in the military's arsenal. If the weapon's headspace and timing isn't set right, however, it's just a huge chunk of metal. Veterans can be rendered inoperable if their headspace and timing's not set correctly either. That's my mission here, to raise awareness about veteran mental health and reduce the stigma against seeking support. Each week we'll talk about different aspects of veteran mental health and interview mental health professionals that are working with veterans, service members, and their families around the country. Hey folks, welcome back to the Headspace and Timing podcast. Once again, I really appreciate you taking the time to listen and spend your time with us. Today, my guest is someone that I've known in the community for a little bit, for probably about a year and some change. And she is also another both veteran and mental health professional. There are more than one of us in the world. And so she is someone that really kind of believes a lot of the same things I do. So I would like to introduce Dr. J. Blair Cano. Blair, welcome to the program.
Thank you. I appreciate you asking me on.
So before we get started, I'd like to let you tell a little bit about yourself and kind of what you do to the audience.
Okay. Well, I am medically retired from the Navy. I served in a training squadron, BF-101, where we trained fighter pilots for F-14 fighter jets. I was an avionics electrician. And when I finished my time there, I was medically retired. I moved here in 2003 to finish school, where I got a master's and then doctorate in clinical psychology with a concentration in neuropsychology. And I also have a master's degree in clinical psychopharmacology. And then I opened a practice in 2009, and we serve primarily the military community, but others as well.
So that's always fascinating to me, and I don't even think that in our conversations that that we ever really talked about how you got into the mental health field. Like me, you were not a mental health professional when you were in the military. What is it that got you interested in working with veterans in mental health or just mental health in general?
Well, several things. Excuse me. My uncle, actually, and a lot of people don't know this, was a Vietnam veteran who had schizophrenia, and he committed suicide when I was 10 years old. And so that had a really profound effect on me, obviously. But in part of that, I had always wondered what role the VA played in giving him services, how supportive they were, how supportive our family unit was. And as a child, of course, I didn't know these answers. And so that was probably the first time I actually started thinking about any of those concepts. And then, of course, when you're in the military, you make friends with a lot of people and see and hear a lot of different things. And I actually got my undergrad in criminology, which is what I thought I wanted to do. And then I realized as I moved through that training that that probably wasn't exactly the population I wanted to work with. So I decided I still want to be in the helping field, so I'll kind of transition to psychology and see where that goes. And it just evolved from there. I think a lot of that happens with a lot of us, where you start down one road and then you kind of find yourself somewhere else. And I have a love for the veteran community, and so here I am.
Yeah, I think that it's real important is to understand, obviously, why we do what we do. Our profession is, as you said, it's a helping profession, but we each have our own personal reasons for doing so. My reason, very similarly to yours, was my father and 3 of my uncles served in Vietnam, and I watched how each of them responded differently to their experiences. My uncle speaks about it to this day. My father, before he passed, really didn't speak about it at all. And so I saw the differences, but also I knew that I could not be, well, definitely couldn't be my father's therapist, my uncle's therapist, but just understanding what that generation went through regarding mental health, for me, was something that I wanted to keep our generation's veterans from having to go through. Is that sort of similar?
Oh, I completely agree with you. My grandfather was in World War II in the Army, and then my uncle was in the Army for Vietnam, and none of these topics were ever talked about. Even upon his death, actually, none of these topics, it was almost taboo. And so when you're in the military and you see people struggling, and you know it shouldn't be a taboo topic, and you know we need to talk about it, but the community is just very hush-hush about it. It just, you know, internally, that's not the right way to deal with things. And so luckily we are in a place now where I think the stigma is less than it used to be, and I'm hoping we continue to move in the right direction where it's more and more less stigmatized.
I agree. And again, you and I have had several conversations about this, sort of not on the podcast. For everyone, Blair and I we work in the same community. We're here in Colorado Springs, and we've had probably 3 or 4 different conversations about this kind of thing, about trying to get the word out to veterans about what mental health actually is, or what therapy is, and really break down that stigma. So you talked about the stigma, Blair, but there's a couple levels of stigma, right? There's the external stigma, but then there's the internal stigma. Which do you believe is greater?
Both and neither. I think they play together often. I think our town is interesting. We are surrounded with military installations here, and so we have an interesting opportunity to bring it into the forefront more, and I do believe our community does so more than many others. Because we have such a heavy population of military, I think that the stigma is higher in other parts of the country where there's less psychoeducation to the community as a whole about what PTSD is, or brain injury for that matter, or moral injury added to that. And so I even did a talk last summer for the Pillar Institute where it was a psychoeducation piece essentially. And I was surprised in this community how many people sat in the audience, and you could tell by their face and their nods, and then they came up to me afterwards and said, wow, I had no idea this is what's going on, but you just described my uncle or my husband or my father or, somebody in my family that's been struggling for years. So I think part of the conversation and opening it up is allowing people to know it's okay to talk about these things. And I think a lot of that is true with regard to the topic of suicide. I know you and I have talked about that, and I believe a lot of people believe that you shouldn't be talking about suicide. You need to not say anything about it, or it's going to cause someone to go ahead and try to commit suicide, when in fact it opens the door in the lines of communications, and more often than not, it prevents a suicide. So I think people need to be allowed internally to feel as though it's okay to express whatever deficits they feel like they're dealing with. But we as a community have to provide that platform.
No, I agree with you. It can be very isolating. It can be isolating for caregivers or those experiencing it, um, and and it's something that almost naturally people want to keep to themselves, and they think that that's protective. But like you said, it's really not.
So I think part of what happens with the internal stigma is if you're functioning at a certain level before you are subject to this, and this happens for people all the time, they're very functional in their job or their assignment, and then they experience the trauma, they have PTSD, and they will say things to me like, I feel as though I have acquired a learning disability. I used to be able to do X, Y, and Z, and I can't do it now. And so internally, of course, for all of us, that feels horrible to know I was functioning at a certain level at one point, and now I can't even do basic things, and I don't understand it, first of all. And then, of course, what am I going to do to get back to good or as close to good as I can get?
Yeah, and I think that's a challenge is many veterans, in my experience, and perhaps you can feel the same with the veterans you work with, is that they think that that's it and it will never get better. Why bother? Why go work with somebody? Because, well, now I'm dysfunctional and the dysfunction is just the way it's going to be forever.
Well, and again, I think that's a lack of education and lack of talking about it. I had an intake with a guy last week, and he was describing so many things that are common to many people with PTSD, and I looked at him and I said, oh, well, that makes sense for this situation. And he said, really? And I said that 4 or 5 times, and he said, nobody's ever talked to me about what PTSD actually is and that anything can be done about it, and I've been diagnosed for 12 years. And I said, so you've never had any of these conversations? And he said, no. And I said, well, I need you to know that for someone with PTSD, these symptoms are normal and we can rehabilitate you. And the look on his face was a mixture of bewilderment. He was happy. I think he was surprised that he had never heard that information. So the mental health community has to do a better job of psychoeducation.
I definitely know that this is something that I ask veterans the same thing is like, has anybody explained to you what PTSD is? And on my limited basis, you're much more experienced clinical basis of the neurological basis of PTSD and things like that. And like you, I'm surprised that veterans or veterans who I work with, sometimes spouses, they're given a diagnosis of PTSD, but nobody ever actually explains what that is. And that's not typical. When somebody is diagnosed with diabetes, for example, they say, oh, this is caused by low blood sugar and this is what it does. And there's an explanation behind what diabetes is. We describe PTSD according to its symptoms, but not its root cause.
Right. Well, and when you're explaining a medical condition, you also say, this is the cause of the behavior changes or the changes in your body, and then this is what you can expect going forward. And those conversations don't happen either. So when people feel this internal stigma, it's because they know things have changed within them, but they don't know that that's normal for what they've been through. And so they feel outside of the norm. But the problem with that, of course, is so many people are walking around with the same feeling. They're not outside the norm. There's a whole group of people who feel the same way. Same with caregivers. They all feel isolated, yet there's a whole group of caregivers who are feeling the same way. And these conversations are happening to let them know you're not alone in this. I understand it. I've been there before, or I've, heard this, that, or the other helps. And so the biggest part of this is isolation, I think.
No, and I agree, and that goes back to this. Nobody ever explained that to me. Nobody ever helped me understand that. And what you've done was just describe my uncle, or or my husband, or what have you. I had a colleague, with the writing that I do, and I was having coffee with him probably a couple weeks ago now, and he was like, you get me, right? It's like, were you in my head? When you wrote that, that's about me. And I think not a lot of veterans feel that. And when they see somebody, they see something external say, I can tell that what you're going through is X, Y, Z, it surprises them.
Oh, absolutely. I think they're somewhat caught off guard because consider part of the PTSD profile is that you're very guarded and secretive often. And so you think you're putting off a certain image to the world and that nobody sees that you're struggling when in fact the people closest to you or who can recognize it do see that you're struggling. And so I think some of it is they're a little taken aback by that. And then I think they're relieved also. There's some level of relief in that.
Yes, we do like to understand why. Like, if you're gonna send me in to get bullets raining down on top of me, just tell me why. I'll still do it, right? But I'll just give me a good an understanding. And maybe at certain times in my career, I was that soldier that asked why one too many times. And when I was a leader, I didn't want to just do what I said. But I think that in my experience, again, for veterans uniquely, just give me something I can understand, and then I know what to do.
Right. Well, and I think one of the reasons veterans don't seek care is they have a misperception of what care would look like. So they have a lot of ideas. One is that I'm going to be medicated constantly, and I don't want to be medicated, or that I'm going to have to sit and rehash all of my traumatic experiences with a stranger, and I don't want to do that either. And so a lot of times people aren't seeking help because they don't know what the process looks like, and that so many other things can be helped without even, you could get better without even talking about your trauma at all. So there are so many other things that can happen. And I think there's not a lot of education about the therapy process in general.
And again, a conversation that you and I have had that many of us in our profession, in the mental health counseling industry, really don't do a good job at getting out there and explaining what we do. We know the product that we have to sell is really great and beneficial, but we're good at practicing. We're not that good at, let's say, marketing. And essentially that's what it really is.
Right. Well, and I think I agree with that, but I think there's another level with the veteran community that's difficult because it's a pretty tight-knit community. And so more often than not, what I think happens is if someone gets in the door and has a good experience, the best marketing tool is that veteran because they will go to their buddies and say, hey, I got the person for you. They get you. You don't have to rehash everything. You can be safe with this person. Hopefully someday you can trust this person. And so the word of mouth with the veteran community is even more of a marketing, I don't know if you'd say tool or advantage, but I believe that's how more of the vets come in than in other marketing ways for the general population.
Unfortunately, though, I think the opposite can happen too, is that if a veteran has a bad experience with one therapist, then they can generalize that to all the therapists, and they go back to their buddy and say, don't worry, don't bother, it was crap.
Absolutely. That can happen as well.
So moving to, and you were talking about what PTSD is and things like that, and I have in my clinical training, an understanding of the neurological basis of PTSD, and I often explain to people, and I think that you've seen it in some of the presentations that I've done. PTSD, I call it an injury of the behavior. It's an automatic fear response, and we're talking straight PTSD, where traumatic brain injury is a physical injury of the brain. So I assume that we'll kind of find something to put in the show notes that listeners can go back and maybe see, these areas of the brain that I'm certain that you're going to talk about. But can you give maybe a brief overview of what how PTSD impacts the brain?
Yes. So in the past, PTSD was thought of as strictly an emotional disorder, so behavioral disorder where, yes, you were hyperreactive to things, and they used to call it soldier's heart. You were having heart palpitations and things like that, and they thought it was only emotionally driven. And that has been a theory for a really long time. It's only been in the last, maybe 10 or 15 years that we've actually changed gears a little bit, and neuroscience has taken over, and we've got more research. So now what we are able to understand is that there are actually fundamental changes to structures of the brain and hormonal systems in the body, neurotransmitters in the body. And so when those structural changes occur, that has an impact on overall brain functioning, not just behaviors, not just the autonomic nervous system, but many different things, memory consolidation. So we're talking about many, many systems. And it used to be thought in the field of neuropsychology that if there was an insult to one part of the brain, it was acutely located just in that part of the brain. It was called a focal injury, and that it didn't impact any other part of the brain. And we now know there are circuits in the brain that work together all of the time throughout the entire brain. So when one of the structures of the brain changes as a result of PTSD, it does have an impact on other structures in the brain. For instance, the amygdala, which people call the fight or flight system, the fear center of the brain, is very closely related to the hippocampus, which is our memory consolidation area of the brain. That happens to be tied into the prefrontal cortex in an area called the Anterior Cingulate cortex. I know these are all big words that probably a lot of people don't know, but essentially what it means is when the fear center goes haywire and is overactive, the anterior cingulate cortex should act like a clutch, kind of like your car, to say, okay, you're overactivated, but let's shut that down for a minute. Let's be able to think this scenario through. But in PTSD, the volume of the anterior cingulate cortex reduces, so that clutch fails to work anymore, more appropriately, I should say. So therefore, the prefrontal cortex, which is our planning, our processing, our reasonable thinking, is not working as well, so it can't shut down those fear responses the way it used to. And that becomes a problem. So then we see things like impulsive behaviors, you can see personality changes, you can see people have a harder time with day-to-day tasks and living. It's also associated with a part of the brain called the insula, which holds empathy. So if we have changes in that part of the brain, people appear to be having less empathy for other people or scenarios. So they're really all tied together, and that's newer information in our field.
Yeah, I've always, I think, explained it as you're definitely explaining it as an integrated system. But to maybe how I explain it to some veterans, imagine someone, you make a fist curled over your thumb, right? And where your wrist would be the brain stem. Well, the thumb that's the area underneath. You're talking about the hippocampus and the amygdala, what people call the reptile brain or the lower brain, and then right. Our fingers curled over our thumb it's the prefrontal cortex, and I often explain that the back part of your brain is the gas pedal. Let's tromp on the gas pedal and let's rev things up to go. Where that front part of your brain is the governor that keeps the RPMs from going too high.
Exactly.
And without the cingulate cortex engaging that, and I like that idea of the clutch engaging the governor to keep it from that. Without that, then it's just all gas pedal all the time.
Right, and that's dysfunctional for people. That keeps you in a state of high alert all of the time. So if your clutch isn't working properly, there are times and scenarios in the civilian world where you do need to be more acutely aware, and there is a present danger that you need to evaluate. But what happens is if that other system, the emotional system, is in hyperdrive all the time, you start to perceive what would normally be innocuous stimulus as threatening, even though it really isn't. And that's part of your clutch not working properly. And so then you feel like you're in a threatened mode all of the time. So your behaviors are adjusted, to be in defense mode, essentially, when you don't need to be.
And there's an embodied component to this as well, because, it's connected to our nervous system. So when the amygdala and the hippocampus and those when that starts, that actually produces physical changes in our bodies.
Mm-hmm. And those are the same things that used to be referred to as things like the soldier's heart, right? When you're having heart palpitations, that means your autonomic nervous system is go, 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 and your parasympathetic isn't working as well as it needs to. An analogy I use with people often is it's like when you're sitting at a stoplight and your car should be revving at 0 RPMs while you're just sitting there, 0 to 1,000 RPM. And instead, your brain is in a situation in your body as well where you're revved at 3,000 RPMs all of the time. So if that's the case, it takes very little at that point for you to become even more hyper alert, to be scared easily, to get angered easily, to be frightened easily. So that becomes your new norm is the problem. And so we have to work in therapy, and there are multiple ways to do this, to kind of reset that system so you're back at a normal RPM, if you will.
And so as you had mentioned that there's been advances in neuroscience over the last 10 to 15 years, maybe even going back to the late 90s, I think, that our brains are actually, they change. You know, we talk about neuroplasticity, and I'll make sure that there's a link to a greater description of neuroplasticity. And I'll start it, and of course you can pick it up, is our brains adapt to the way that we think, the way that we act. I think Freud, even way back in the day, said that neurons that fire together wire together. And so if we don't have this control over the hyperactivity, then there's a greater chance that we're going to continue that, and that I'd say there's a mile wide superhighway between the lower portions, the emotional activation portions of our brain and our nervous system, but there's a footpath from the front part of our brain, the prefrontal cortex, back to the emotional side.
Right. Yes, and so neuroplasticity, again, like you said, is kind of a newer idea. It used to be thought that our brains were finished growing, if you will, around 25, and then that was it. You got what you got for the rest of your life, and if you had an injury, that was it. There was no rehabbing it. And so now we know that's not true. Our brain is plastic, meaning it changes until the day that we die. So there is always hope of changing behaviors, changing the structures in the brain. For instance, there's been some research on mindfulness, meditation, and that literally just sitting in silence helps regenerate neurons in the brain. So yeah, there's really new science coming out every single day, as a matter of fact. And so that's helpful for me because that means that we can rehab people. PTSD is not a curative model, meaning thus far nobody has found one way to cure it. But you can rehab people either very close to where they were originally or to a new norm that is functional for the life that they have now. And that can happen with medications. That can happen with things like neurofeedback. It can happen with psychotherapy. Just the attunement of a good relationship and mirror neurons can change other neurons in the brain. So there are many methods now. Prayer is the same thing as meditation, having your strong faith. So there's many, many ways to rehab your brain and your soul.
Now, and definitely want to get into some of those different methods that can help change and kind of develop different behaviors. But the impact of trauma on some of these regions of the brain. You've heard people talk about the battle-scarred amygdala, and there have been studies that showed repeated exposure to traumatic or crisis events result in lower hippocampus volume. Like there's parts of your brain that shrink due to repeated trauma.
Correct. That is true of the amygdala. The latest science on the hippocampus would say, did it lose volume because of the trauma, or do people with smaller volumes, are they predisposed to traumatic experiences? And so that one is not clear, but the amygdala is absolutely clear. The volume loss in the anterior cingulate cortex and the insula is clear as well. And we're able to see that through PET scans and certain types of imaging. You can't necessarily see that on an MRI, so that's not as clear, but we're having more and more advancements that are going to demonstrate this to us in the future.
Yeah, and so the way I explain to some veterans is, let's say, these areas of your brain, they're a blank sheet of paper, and then if they're constantly bombarded by stress, cortisol, all of the hormones and everything, the adrenaline, all of these things. And so then the paper gets wadded up in a ball and crumpled. Some of these treatments can help smooth that back out, but it's never going to be the same pristine piece of paper that it was before. Would that be accurate?
That is completely accurate, and that's a really good point, and I'm glad that you brought it up, because I believe that is a misnomer in the field, and that people have been told, or for some reason do believe, I'll go through a certain treatment and then everything will be just fine again or perfect again. And the unfortunate truth is trauma does change a person on so many levels. And no, you will not be the exact same again, but you can be a very good version of yourself, and you can be a new and improved version of yourself in other ways. So that's a really good analogy, and I'm glad that you brought that up.
Well, and I think that, and again, we're very similar, work with the same population. I hear it all the time. Veterans will say, well, I just want to be the 17-year-old me. I just want to go back to being who I was before. I was a class clown. I was the jock. I didn't have any problem talking in front of people. Can I just go back to being who I was before? Typically what I say is, I don't want to be the 17-year-old me, because that guy was a moron. Right, I want to be. Right. I mean, it just all of my life, my lived experience, I want to hold on to them, but I don't need to be the shuddering, shallow part of who I am. We temporarily, time wise, there's no going back, but psychologically, there's no going back either. I'm not a big fan of the idea of a new normal, because normal is developing, and you always have a new normal, But exactly what you said is you can be a better version of who you currently are by integrating all of these things.
Well, and I think along with that is bereavement. So part of therapy should be, when people say, I want to be my old self, I want to be my 17-year-old self, part of what they're saying is, I feel a profound sadness and sense of loss, just like a death, right, of who this image was, and I need to process the fact that that's not who I am anymore, and that's not who I'm going to be. And I don't know how often that is addressed in therapy, but I think that's a big piece. So there's a bereavement piece that has to be worked through, because there is a loss of sense of self there.
Yes, and then we get away from PTSD itself, traumatic brain injury itself, and this goes more into the realm of existential psychology of, what is my definition of self? What is my definition of meaning and purpose? And the bereavement of losing my military. I'm no longer Sergeant France anymore. I'm no longer have that identity. A fellow co-host on the podcast network here, Jeff, said that when he was medically retired from the Army, he could no longer be allowed to be who he was. That the Army said he couldn't be him. And for me, heartbreaking, but a lot of veterans see themselves as that, and that's an aspect of, that's not a diagnosable condition, but it's a very real aspect of veteran mental health.
Oh, absolutely. Well, there's a loss of community that goes hand in hand with that when somebody is either medically retired, or it's just time to retire, or they choose to leave. Any way that happens, there's a loss of community, and this is something that I do not believe civilians understand fully, is the community you develop in the military, even if you don't like the guy next to you. It's a very strong bond anyway, and the experiences you go through solidify that bond, and to lose that, no matter how that occurs, is very difficult, and then to reintegrate into a new community, meaning the civilian sector, can be very, very difficult. And often people feel isolated because they realize, I no longer am fitting into the military community, but I really don't fully fit into the civilian sector either. So I'm kind of in this no man's land in between. And so who am I in this middle area? And that's a really hard place to be for people.
I really like that. Again, another common statement that another one of the hosts talks about, he said, you'll never be a civilian. You're always going to be a veteran. That a veteran is a total third entity, a thing. You're not a civilian, even though you wear civilian clothes, because you see things, and I've written about this, you see things through a veteran filter, but you are also no longer a military person as well. And so you're this total third thing. One of the, I guess an example would be military children who they don't have any place that they're from. My kids aren't from anywhere because they were Army brats, and
Right.
so it's this grounded. It's a sense of identity that is not really well defined.
Absolutely, I agree.
So, in going to the idea of now that we know that trauma does impact the regions of the brain, that there are different treatments that can help increase that. We're talking about different volume in the hippocampus or the amygdala that's overactivated, the lower volume, the cingulate. All of these different things, and I've seen research, and you've mentioned some briefly that can help bring that back. It can increase volume. That like certain treatments can and have proven to bring back to a level of functionality.
Mm-hmm. Right. And so, for instance, one of the methods that we use, neurofeedback, helps retrain the brainwave activity, which also works hand in hand with your neurochemical makeup. And so we're able to kind of adjust things from that angle. Psychotherapy, research that I've read in the last year actually said psychotherapy and medicine work equally as well to treat PTSD as a whole. It's just an individualized approach, meaning one person will respond better to one or the other, but neither one works better than the other. So both those methods help regenerate parts of the brain. Again, are we going to have complete regrowth of that certain structure? That has yet to be determined. However, we can see growth in many other parts of the brain. And so the brain also starts to use, if certain circuits are shut down, if you will, it starts to use other parts of the brain. It recruits other neurons. And part of therapy as a whole is aimed at redoing that, regenerating these neurons and communication tracks.
Yes, and I like that you brought that up. I often describe that as borrowing real estate from next door.
Exactly.
People talk about how when someone loses their sight, then their hearing becomes sharper. They lose one sense, and another sense becomes more sensitive. The way I explain it is that basically once that region of the brain that was responsible for auditory input from hearing, for example, once you're no longer getting activity there, the visual cortex will say, hey, you're not using that real estate. I'm going to borrow it, and I'm going to spread out over there, and I'm going to take some of that.
Mm-hmm. Which is really exciting, and that's why the field of neuroplasticity is so exciting, because remember, we used to think that was impossible, and now we know it's happening all of the time. So I think that's really exciting science. And I'm excited to see what more we find out about that and how compensatory the brain actually is.
And so in one of the ways to help develop that and this is it's like, well, if I just think positively, then I'll be more positive. Well, science says yes, right? That it kind of does work that way. And the opposite is also true. If you think negatively, then you're going to be negative. But one of the ways that you say that you help, and we do a certain kind of thing too, is neurofeedback. So when I describe biofeedback, neurofeedback, and my way I can start, and again you can go, is biofeedback is your Apple Watch, right? A heartbeat monitor, where there is some measurement of a condition of my body, a blood pressure cuff is biofeedback. It's measuring my blood pressure, and it's responding back to me, so I can see it from external. So that's sort of biofeedback. Neurofeedback is the same thing, only using brain waves. That's a very simple way. So could you expand?
Absolutely. So you're exactly right. Neurofeedback is brain-based biofeedback, and there are many different types, but essentially the same thing is happening, is we are getting information from the brain, whether it is behaving underactive in some areas, overactive in some areas, like we had talked about previously. Often there's a mixture of the two, right? We have both of those things happening at the same time. And so it essentially gives the brain the information via a visual and an auditory screen to say, okay, this is what you're doing, but this is what you need to be doing to either increase certain levels of activity or decrease levels of activity. So it's retraining those brain waves to be less aberrant. And it's very effective. There are various types, so some of them put no electrical input into the brain. Some do put electrical input into the brain. Both have been found to be effective, so it doesn't really matter what type you get per se. The research on the various types demonstrates that they all work to some capacity. So in our practice, we combine neurofeedback with psychotherapy because I believe the more plastic the brain is and the more it changes and calms down, the more receptive people are to the feedback they're getting via therapy, and they're better able to implement those changes outside of therapy.
And so neurofeedback does help induce a more calm state in the brain, as you were saying, the overactivation. Can you talk briefly about the different wavelengths, alpha waves, gamma waves, that kind of thing?
Right. So think about, delta waves are what we are producing when we're asleep. So the only time we really want to be producing a lot of delta is when we're sleeping. However, if you're profoundly depressed or you've received a brain injury, or we have shrinkage in certain parts of the brain, you produce more delta and theta waves during your day waking hours, which is kind of sluggish, right? So that's the whole, I'm having a hard time getting up in the morning, I'm feeling this brain fog all day, I feel sluggish all the time, I can't feel happy about things. And so certain brain waves we want to see more active at certain times of the day. So the theta and the delta are, I call them gunky. They kind of bog the brain down. Then we move into alpha. Alpha is kind of this really nice, calm, cool, collected state where you're calm, you're relaxed, but if something were to walk in front of you, you could be aware of it, but you're not hyper aware of it, right? You're not going to be hyper aroused by that stimulus. Then we move into beta 1, 2, and 3, and those are different levels of activity we need to see in the prefrontal cortex, for instance. So when you're planning and you're processing and you're thinking about how am I going to get all the stuff done in my day, or how am I going to pick up the kids and then get over to soccer practice and da-da-da-da-da, you need some of that beta happening in the prefrontal cortex, or else you would not be able to plan and process like that. And so sometimes beta goes haywire on us and rides herd, if you will, too much of the time, and that produces overactivity throughout the brain, and that's where we get symptoms like insomnia, hyperreactivity, being on alert all of the time. And so it depends on the type of brainwave activity and what part of the brain is producing it. That's what we're looking at trying to modulate.
And so, and there are different types. In here in Colorado Springs and other places I've heard around the VA, they've used a device called the Alpha Stim. It's a device that stimulates alpha waves, or it simulates alpha waves, and then the brain's responsivity, going back to that neuroplasticity that you were talking about, the brain sort of synchronizes with the alpha stim or different types of neurofeedback to say, okay, I'm basically going to synchronize with this calmer pulse.
Correct. That's correct.
And so I think this is an important thing for many practitioners to understand, that there's actually hard science behind not just PTSD. That I actually, and I'm not going to go on a rant, but earlier today I was listening to someone said that PTSD was just a throwaway diagnosis, that when they didn't know what else is wrong with you, they just slapped PTSD. I respectfully disagree, based on my clinical experience and the science that I know of, that it actually there's a clinical or a scientific basis to PTSD, but also there's a scientific basis to the methods that actually work.
Absolutely, and with neurofeedback, we are getting more and more research, and there are actually DoD studies on some of the bases across the country that are measuring the outcomes, and so I believe we'll see more and more of that research coming forward. In our field, in the trauma field, Bessel van der Kolk. I'm not sure if you know. I know you know him, but if others don't, he's kind of the guru of trauma, if you will. And he has been producing some research most recently with I don't remember which neurofeedback method he's using, but so there are some big players in the field doing really good research to substantiate its effectiveness, and we will see more and more of that coming forward.
Yes, definitely. And again, Dr. van der Kolk is also very big in embodied trauma, how trauma manifests itself within our physical bodies. But also he's done a lot of research on, as you had mentioned, mindfulness, meditation, but even yoga and things like that. And it's definitely not as simple as loud noise goes off and, we hit the floor. Definitely that happens, but it can be much more complex, both as a standalone condition, PTSD itself, but also in the wider range of veteran experience.
Well, absolutely. And the somatic experience is important because an important piece of information that I don't know how many people know is that the cells in our body have memory of their own, separate from our ability to recall things in our brain. So children, there's a lot of science for children that before you are able to acquire language, if they go through trauma, their bodies react in a way independent of their cognitive memory and their ability to verbalize. And when you're in the middle of combat and all these things are happening, your brain does at times kind of shut down and dissociate to preserve you, actually. But that doesn't mean that your body is not experiencing those same things. And the body cells hold on to that memory, and that is a separate type of memory. So somatic therapies, all of them, are very helpful because of that reason.
And when you're talking somatic therapies, things with, there's definitely yoga, right, or Tai Chi or some type of meditative movement. But there's also just physical interacting, walking and talking and hiking, and this is where exercise is also good for mental health and things like that.
Oh, exercise. So this is really interesting. And I know it's hard when people are depressed because they feel such avolition, they don't want to exercise, and that's part of where we have to come in to help motivate. But exercise has been proven to be as effective as antidepressants for treating depression and anxiety. It's been proven to be more effective in the treatment of Alzheimer's disease than any of the medications. And for the Alzheimer's population, actually, it's dancing that they've done the most research with. So exercise as a whole is so vitally important to everybody. If we did nothing else, actually, exercise would do a lot to heal us.
Great. So now my wife's going to listen to this and say that now I need to take her dancing because that's and I don't dance. I do a lot of different stuff. I can sing, I can talk, but I don't dance. But thanks, Blair. Now I have to do that.
You're going to have to do that so you don't get Alzheimer's, you see.
No, and this has been great. I think this has been a really great overview of the neurological basis for PTSD, and I know that I'm going to send a link to the article that you wrote on the Headspace and Timing blog and include that in the show notes, and probably, like I said, I'll dig up some examples of the brain regions we were talking about. We didn't even get to talk about traumatic brain injury, so we'll have to have you back on the show, talk about that and the impacts of traumatic brain injury, it being another one of the signature wounds or signature conditions out of the recent conflicts. So if people wanted to learn more about what you're doing or some of the stuff you've talked about, how can they find you, your website, stuff like that?
Well, my website is www.cano, C-A-N-O, neuro.info. We have a lot of information on neurofeedback. I put a lot of the articles that I write on there under the blog section. My email address is also on that website, so people are welcome to email me at any time with questions. And I would love to come back and talk about TBI because this last set of wars is where we're getting the most data about TBI, where this was not available to us in the previous wars, especially Vietnam. We didn't have as much TBI then as we have had in this last set. And so the research has expanded. We know some new things. We know a lot more about how TBI and PTSD can correlate. And so that's really important information as well. And I would love to come back and talk about that.
Absolutely. So thank you so much for joining us on the show.
Well, thanks for having me. I really appreciate it.
Absolutely.
The struggle is real, found a feast and lost a soul. Eventually my drinking, it got out of control. There in darkness I roam, struggling to find home. See, suddenly death didn't feel so alone. 22 a day, destination unknown. It could have been avoided if you picked up the phone, but now you're gone, so I guess all we get is the tone. Nothing but bone weeds, overgrown, pushing up stones. I've triumphed over enemies, co-created mini-me's. Broke out facilities that tried to put an end to me. R.I.P. I'd rather grind in tranquility. Authentic tendency, embrace my ability.
So there you have it, folks. Another episode of Headspace and Timing, a show dedicated to changing your perspective on veteran mental health. I'd like to thank Doc Todd for giving us permission to use the track Not Alone from his amazing album, Combat Medicine. Doc's a guy who's trying to bring the discussions about veteran mental health out of the darkness and into the light, and you need to check him out. Head over to therealdoctodd.com to purchase the album and support the cause. You're not alone, veterans. Ever.
The struggle is real, found a feast and lost a soul. Eventually my drinking, it got out of control. There in darkness I roam, struggling to find home. See, suddenly death didn't feel so alone. 22 a day, destination unknown. It could have been avoided if you picked up the phone, but now you're gone, so I guess all we get is the tone. Nothing but bone weeds, overgrown, pushing up stones. I've triumphed over enemies, co-created mini-me's. Broke out facilities that tried to put an end to me. R.I.P. I'd rather grind in tranquility. Authentic tendency, embrace my ability. Gave every shred, every last thread of my identity. Conquer my fragility, eliminate the enemy. Deliver me, God, from temptation. Tell me that this life is just a matrix. Need a facelift, back to basics. Vision LASIX, I only feel alive when I hear the bass kick.
Oh, I try so hard to have faith. I bow my head and I pray. Lord, please lend me the strength to carry on and keep standing. How this life so demanding. So much pain on this planet. I heard each time my way, but with you I'm not alone.
Not alone. You're not alone.
Oh yeah. And every time that I fall, I'ma call on you, pick myself back up again.
Yeah, just pick up the phone, you're not alone. Just pick up the phone, you're not alone, man. Just pick up the phone, you're not alone. Yeah, pick up the phone, I'm right here. And I love you guys. Take those bottles out, dog, and pour them in the sink. Take the needles out your arm and the gun away from your forehead. It's time, man, you've been through enough pain, stand up. It's time to stand back up. All my veterans, man, Army, Marine Corps, Navy, Air Force, Coast Guard. Get up, you know.
Oh, I try so hard to have faith.